Hello, and welcome to the Health GoLive Webinar series. Today's episode is brought to you by our friends at Brightside Health. We would like to remind you that the Q&A feature is available, so feel free to set in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Brad Kittredge, CEO and co-founder of Brightside Health.
Hello, everyone. Thank you so much for joining us today. I'm Brad Kittredge, the founder and CEO at Brightside Health. We're fortunate to have three amazing experts here with us today to talk about delivering high-quality mental health care to high-risk, underserved populations. And let's introduce you to our panelists. First, we have Cara McNulty, the CEO at Vibrant Emotional Health. We have Dr. Tom Zobler, Chief Medical Officer at NeuroFlow, and Dr. Therese Garrett, the Behavioral Health Medical Director for WellCare North Carolina Health Plan. Thank you all for being here, and Dr. Garrett, particularly given everything that's going on in North Carolina, we're sending all of our best thoughts and wishes to everyone affected and everyone caring for them. Please note that our session is scheduled to be about an hour today. I expect that our discussion should go about 40 minutes or so, and that'll leave plenty of time for Q&A at the end. We can do live questions during that time. You can also relay them through the chat function at any time, and I can help address them with that. So let's jump right in. I know we're all excited about this topic, and I assume everybody that's in the audience is interested and eager as well. So let's talk about the current situation and the challenges that we're seeing in the market as it relates to access to timely and quality care, again, especially for these patients with elevated severity and acuity. Cara, from your perspective in both the payer and the nonprofit space, what are you seeing in terms of access to care and the primary barriers for this population? And how does that really fit with the narrative of the broader mental health crisis?
Sure. Thank you for having me, Brad. It's great to be here. There's so much here, having been on the payer side, on the provider side, and now on the nonprofit side. I think all of us can agree that we talk a lot about access, but access is like the lowest threshold. It is access to timely care, quality care, appropriate care for the individual and their ecosystem. And I'll talk about that. And how do we make sure that we aren't creating more barriers in how we are putting together the care continuum in behavioral health? And what I mean by that is, having been on the payer side, we often had a great deal of providers, but technology was a barrier for us to connect our members to our providers. And so how do we advance the technology ecosystem so we can get people connected? Now, being on the nonprofit side, technology is more agile for us, but getting people access to care before they're in crisis is an issue. And so I bring all that around to say, I think it's just human nature that when things are happening and all of us are passionate about improving this mental health ecosystem, and most of us can say, we don't often experience people who say, I've been in the mental health care system and it was just a fantastic experience. I know exactly where to go, how to get help, who to get help from. And I mean, just incredible. Most of us know that's not the conversation, but that's what we're striving towards. And what I am seeing, having sat on the provider, the payer, and now the nonprofit side, is just a reinforcement that none of us can do it alone. And it might be easy for me to think, oh gosh, the payer system, they should do X, Y, and Z, because then we would solve this. Or the provider system needs to do this, this, and this, and then we'll solve it. And the nonprofit needs to do X, Y, and Z. But we all need to do it together. And we need to continue to focus on how is the people we're serving at the center, and what's that experience. Every place we're creating more disruption or more barriers or more opportunity to lose people through the safety net what are we doing to fix it? And so having now been on all of these sides, it's even more important for me in wanting to be a solver of problems and a solution to a broken system. What can my organization do? And where do we fit into the equation? And then where do we need to get out of the way? Where do we need to make sure that other people are doing it? And how do we create this seamless ecosystem and strive for people leaving the a mental health system by saying, gosh, that was an exceptional experience. That was an exceptional experience. And I don't want it to just be access. It's access, it's quality, it's do we have the right match with provider and patient? And then what are we doing for their whole ecosystem? Because it's not just a one and done, and maybe it's what's presenting as a serious mental illness, but we know with that comes other social determinants that we need to address. I'll stop there.
That's great. Well, thank you. I think it's clear, the range of inputs necessary to be able to solve it and the interdependencies and the complexities of doing so. Could you just summarize from your perspective, if we talk about the broader access issue and the nuance of it as it relates to perhaps subspecialties and different types of care for the right people, do you see the access problem getting worse or better or about the same as it was a few years ago?
Oh gosh, I'm such an optimist. So part of me, realistically, I do think it's getting better in certain areas, in certain communities, in certain, for certain populations. We still have lack of providers in subspecialties. We still have gaps in care when it comes to certain populations. And, I know Dr. Garrett will likely touch on this. We also have gaps when it comes to, it's one thing to maintain an ecosystem when everything is going well, but what about when we have disasters or major crisis? How well are we making progress? So I do think we are improving access. I still think we have a long way to go to fill the gaps in provider specialty, in ensuring our technology really connects and makes that the experience more seamless. And then also that we are providing a system that isn't just about first access. It's about access. It's about quality outcomes. It's about what's the booster or the wraparound we're giving that individual so they get the care and support they need. So I do think we're getting better, but we have work to do.
Yep. I hear you saying that there are certainly pockets where access is harder, and that first appointment access is not necessarily the right measure of access and our collaborative success here. Dr. Garrett, let's move on to you. I know you spend a lot of your time focusing on the Medicaid population. What are the unique challenges of the members that you serve when it comes to access to that type specialized kind of care that they may need with higher severity needs?
Sure. So I think part of it relates not just to the access in terms of provider availability. Do we have providers? Are the providers in the right spaces? But also around issues like stigma. Are folks willing and interested in going to seek out providers? Are the places that they're going places that are going to be places and providers that are going to be culturally and linguistically responsive to their needs? What is some of the history within that area or region around how mental health has been and the way in which people have been treated? Like, how do we increase trust amongst populations, I think is one piece. Another piece relates to how are folks sort of getting to or accessing things that are there, whether we're looking at geographic limitations, whether we're looking at travel limitations that may not necessarily be, is there transportation? But if there's transportation, it's going to take you 2 hours to get to and from an appointment, you may be more likely to put that off, even if there is going to be a ride that's door to door. And that's one of the things that with some of the shifts that happened with COVID, I think one good thing that came out of the COVID era is the rapid expansion of telehealth, and that sort of happening in so many places. One of the things I saw on the provider side, sort of very early in the pandemic, is that I was able to see people more frequently. So somebody who I might historically have wanted to see in a week or two, but realistically we'd say, why don't you just give me a call in a week or two and we'll just check in briefly and then we'll meet in a month. Because of course they weren't going to be able to take the time out of their day to come in. Once we had broad telehealth access, we were able to have that check-in in a week or 2 weeks where they were sort of sitting in their car during a break from work, or just before they went into work, or after they dropped off their kids at school. Or if I had the kid there, I was able to get the parent in virtually through telehealth to do some of that in ways that hadn't been an option before. I think that's one piece that has been there. Another piece that ties back into some of what Cara was saying was about the experience that people have within mental health systems. A large percentage of folks enter the mental health system through crisis settings, which oftentimes is the emergency department. It may be inpatient settings, it may be detox settings. No matter what we all try to do, those are never going to be the friendliest, warmest places that all of us want to spend our free time. And so what are the ways that we can be working on things upstream so that people's entry to the mental health system and their first experience is not crisis or inpatient or detox that may turn them off to be, even if the providers there are great and even if everybody's doing everything they want to, and everything that's best for the patient, how can we make it something that folks want to continue to return to? Because we also know that sort of the average number of times people come in for mental health services is one, which is, great if we're trying to measure this based on intakes or, how many people we saw, but it's not great if we're really looking at, are we caring for individuals? Are we helping people to get better? So what is getting in the way of people coming back in? What are the ways that we can be a place that people want to come and be folks that people want to come see? And that's going to be our work sort of in the behavioral health space, but also quite a bit in the integrated care space, in the primary care side of the house. We know that at least for our population, between 2/3 and 3/4 of services for individuals where the primary diagnosis is behavioral health or substance use happen within physical health settings. And so we want to continue to increase that care and the proficiencies and expertise within those settings, and also have those folks working in those settings have access to communicate with and coordinate with behavioral health professionals, whether that's through consultation lines, whether that's through collaborative care, whether that's through synchronous telehealth, whether that's through asynchronous consultations. There's a variety of different ways that we can do that, but we need to put the brain and the body back together so that we're all sort of working together on the same piece. And it's not like, okay, well, we're doing this piece over here and we're doing this other piece over here, and we don't ever kind of come together there. So I think those are a few of the issues that come up, but I really think sort of as we're looking at this and talking about it, this upstream piece is going to be so important. There are some really exciting things happening within crisis spaces, within emergency work. And as we're doing that, I want to make sure that we're not just sort of building a reactive system, that we're building a system that is proactive and preventative, sort of looking not just at adults from the preventive space, but also can we be looking upstream with children and families to see how do we build functional and supportive sort of family and community systems that will support mental health.
Great. Thank you for those insights. And similar follow-up to Cara is, how do you assess how maybe Medicaid more broadly, not necessarily just your plan, is performing now in terms of being able to support, the mental health needs from an access standpoint of the broader population and perhaps some of the specific populations relative to what you think we need and what's possible? Is that getting better, worse, or staying the same? And what do you see as the trends?
I think it's getting better in some places and getting worse in other places. That's probably not the best answer, but I think one of the pieces that we have and are developing in is being able to use some of the data that exists out there, whether it's data looking at in substance use, whether it's data looking at ED visits and overdoses and overdose deaths, of which there has been a significant reduction in the past year. I'm not sure that we have a great sense as a nation as to whether we're all intentionally doing something right, or whether that just happens to be a something that's there that we can hopefully capitalize on. But historically, we haven't had great information or great data to really look at where are we making improvements, where are there opportunities. I know North Carolina Medicaid as a whole has some really excellent dashboards that are sort of looking across at sort of multi-payers in terms of some of these things. We're looking at substance use, like substance use ED visits and overdoses. There's a dashboard where we can look at visits around sort of self-harm and suicidality, where folks are being prescribed medication or not prescribed medication, where folks are getting therapy. And I think being able to sort of look at that is one piece. And with that, we also need to be aware of sort of what we're missing with the data. Because if we look, for example, at ED visits and what counties are those individuals from, we might then assume, oh, the counties that these folks are coming from, those are where we need more crisis services. But what about the people who never made it to the EDs? So what are we doing also to look from an equity lens about what is the missing data, so that we can really look at what the needs are and not be misled by what we're seeing in the data.
Great, thanks so much. Dr. Zobler, I think that's a good transition into care navigation. Dr. Garrett just mentioned that a lot of people may be falling through the cracks and need care, but not be getting it, not be showing up in our statistics. Others, as we know, have long wait times between their symptom onset and their first encounter. From a navigation perspective, and both identifying and helping patients find and receive the right care, what do you see as the main barriers right now?
So nice to be here, and thank you for having me. So I want to just pick up on something that Dr. Garrett was just saying, and then address the navigation question. We have a misalignment, right? We know that most patients with behavioral health needs will present in medical settings, and yet about 95% of all behavioral professionals work in either primarily or exclusively siloed behavioral health settings. So that misalignment means that we're not really targeting the resources historically where they need to go. And it creates from a navigation perspective, it creates a real challenge, because we're just really capturing the tip of the iceberg. And when you start looking at issues around equity and disparities of care and so on, we know that those who present to behavioral health settings are very different than those who get their care met through integrated care settings in primary care and other medical settings. And so part of the challenge is how do we look at creating a full continuum of care across behavioral health settings, primary care, and acute care. And the other challenge is that care becomes very fragmented, frankly, at both ends of the acuity spectrum. We probably don't do enough in our healthcare ecosystem to manage sub-threshold symptomatology and rising risk, yet we know the evidence base is very clear that a significant percentage of those with sub-threshold depression, anxiety, progress to threshold anxiety, depression, and similarly, those with depression, anxiety, and other illnesses are at higher risk for acute distress and suicidality. So managing that rising level of risk and identifying patients with predictive analytics, and now that we have large language models and other really, really incredible technologies to pick up on that risk, we can be much more proactive in sorting out not just who's at risk today, but who's going to be at risk tomorrow. I think another challenge is how we go about asking the questions that we ask. There's this premise that there is a buildup of distress and behavioral health acuity over days to months to weeks, maybe even years, and that there's a crescendo, and that's when people reach for help. And that's not actually the case. We know, in fact, when you look at suicidality, that suicidal ideation doesn't really predict very well suicidal behaviors at all. There's no other place in perhaps all of medicine, from my perspective, where there's as much of a disconnect where the research is taking us and what we do in clinical practice, because we continue to ask questions, are you suicidal? We continue to have scales which are validated scales, ask in the Brief Columbia and so on. You know, we ask questions about suicide, but we're not necessarily getting at things like, you know, as Craig Bryan or Rudd will say, you know, unlovability, unbearability, how burdensome people are feeling, and asking questions along just from a different perspective to really get at risk, and sometimes disconnecting that acute risk from an actual behavioral health disorder itself. Using the PHQ as a screen for safety can be very problematic. First of all, there are a lot of primary care practices and other practices that don't want to ever ask the 9th question, that question that targets suicidality, because there's so much concern about surfacing risk and what do you do and so on. But just the fact that you're using a depression screen to screen for suicidality is problematic because you're missing a lot of cases. And so I think the challenge from a navigation perspective, and really it's looking at it from a population focused perspective, is how do you try to address these issues across an entire population? How do you proactively identify who's at risk and look at it from the perspective of managing those at all levels of risk, preempting risk from becoming more acute, and also tracking it with assessments and scales and using ecological momentary assessment measures, you know, these measures that look at very sometimes rapid fluctuations and how one feels to pick up on risk when individuals are at the greatest risk, to minimize patients from going to the emergency room or worse. So I think there is a lot of work to be done, but I'm also extremely optimistic that we are moving in the right direction. There are not enough of us behavioral health professionals, you know, so using technology as a force multiplier to be able to provide those digital guidance and interventions, and also clinical support, decision support to care teams, can really help us hone in on those who are most at acute risk, and deliver interventions that can be really very effective at a critical moment in time.
Thank you. That's great. So, you know, given that context that we've talked about, you know, everything from screening and monitoring all the way through navigating people into care and then keeping them in care and in the right care based on their individual specialized needs. Let's talk a little bit about the opportunities to address those challenges and where we see the potential to really move the needle going forward now in a way that hasn't been possible in the past. Dr. Garrett, let's start with you. How do you think are payers looking to identify patients with these needs, perhaps in some similar ways to what Dr. Zobler just talked about? How do we go upstream a little bit, identify people who are at risk or perhaps in the moment when they need care, and ensure that we're finding the right member at the right time to get them into the right care?
Yeah, so I think Dr. Zobler started talking about some of that that ties into predictive analytics, and I think that that's a really big piece in terms of looking at what are some of the aspects that we have not been able to measure before or have not been able to look at in a very broad-based way to identify where are some of these individuals with rising risk, not the folks who are coming in crisis, but the folks sort of before they're coming in for crisis, because it may not be like Dr. Zobler said, where there's this steady march that we're seeing, and especially that depends upon the populations. In particular, if we're looking at children, oftentimes they may be able to be held quite well within the system that they're in until things are really bad, because they've got the school system or they've got supportive caregivers or others that are trying to avoid sort of taking them in for mental health or taking them in for emergency care, because it's not bad enough yet until it really reaches a point where it's boiling over. And so what are some of the ways that we can use predictive analytics to be looking at some of these folks and identifying them early so that we can be doing outreach, whether that's sort of care management outreach, whether that's through coordination with some of our primary cares and care coordination supports and others in those settings. How can we identify folks that may need more than outpatient services? Maybe they need some services that include wraparound. Maybe they're going to need additional day supports. Maybe they're going to need a different team-based model of care than they've been receiving, so that we're not just looking at the quantity of care, but looking at what are some of the higher quality care that we can be getting. I think also, obviously, we do need to use the data that we have. So we are using claims-based data, whether it's, medical encounters, behavioral health encounters, pharmacy claims, to be looking at where are individuals presenting for care, not necessarily for behavioral health conditions, but can be for other conditions. So if we're talking about, for example, an IDD population, we may have someone who's going into the emergency department 10 times in a month for a variety of different things: leg pain today, a wound they're concerned about on their arm tomorrow, a fall another day. And that may be what's going on in those situations, but it may really be that there are additional behavioral health or IDD supports that that person really needs in order to be managing what is happening for them. And so how can we be looking at some of those folks, identifying them and connecting them to the needed supports, both within the behavioral health system, but also sort of across the health system, whether we're looking at private duty nursing or personal care services or a variety of different things, to really knit that together in a way that is more integrated and less discontinuous than it has been historically. So I think that those are pieces of it. Also, of course, in terms of connecting individuals to care, there are people individually reaching out, whether it's through member services, whether it's through connecting with their primary care provider or behavioral health provider. I don't want to discount the sort of directly folks identifying either themselves or their healthcare providers or other non-clinical supports being aware of it. But there are other ways we need to be looking out, because as Dr. Zobler has said, we're not often seeing some of the folks that are struggling the most.
Apologies. Dr. Zobler, you talked about screening and monitoring people to identify when they're having these moments. Maybe you could just build upon that a little bit to say, as soon as you might identify somebody who has a specific set of needs, I imagine there are many branches in the process of where you want to help them find the right care. So can you talk about sort of what's possible and ideal in that pathway, how once you've identified someone, you make sure they're getting the right care for their needs in a timely way?
Yeah, no, absolutely. So I think that there's a fair amount of screening that goes on today. I mean, it's done for the right clinical reasons, there are regulatory reasons. The problem is, how much is that screening really incorporated into workflows and clinical care, and is it really driving people to get the care that they need, and surfacing underlying behavioral health risk across populations? And so I think part of the challenge is to be able to disseminate true population screening in a way that is more robust and integrated with clinical workflows. And then when the results come back, there's also clinical decision support for care teams so that they have an understanding of what to do with that. The reality is that our colleagues, I'm a psychiatrist, our colleagues in internal medicine and pediatric, less so in family medicine, but don't get a lot of training in managing psychiatric problems. And if one is fortunate enough in primary care or OB-GYN or oncology to have psychiatric resources that you can refer patients to, that's wonderful, but that's often not the case. So it's really important to provide guidance for our colleagues in other disciplines to manage these problems, because often patients, as we've just been saying, are not going to present in behavioral settings. They may present in emergency rooms, but that's not an ideal place to be the de facto mental health center for most of the behavioral health care ecosystem. We want to be able to preempt that. So part of it is population screening, true population screening, and integrating into workflows. A second piece of that is the nature of the screening and how adaptive that screening can be. Screening with a PHQ-9 to screen for suicide really may not be adequate. Especially if you're doing a PHQ-2. There's just a study in the Annals of Internal Medicine, really wonderful study, looking at something that Kaiser in Washington State is doing to address suicide. And what they found is, by doing integrated suicide prevention, there was a 25% reduction in the rate of suicide attempts. But they used a PH, and I say this with all due respect, they used what looks like a PHQ-2 and then in turn a PHQ-9 to screen. So, and that's true for a lot of the work that goes on clinically, and it leaves a lot of that risk untouched, unaddressed. And so being able to use asynchronous screens, and there's a burgeoning, I shouldn't even say burgeoning, an emerging evidence-based for doing asynchronous screens for suicidal risk. And how do you go about doing that? But we've got to get more comfortable with that. We've got to publish more. We've got to demonstrate the efficacy of that, and therefore determine, who is really at risk and who's going to be at risk, a week from now or 2 weeks from now. There's evidence that if you use, as I mentioned before, these ecological momentary assessments, they can be mood trackers, these very quick snapshots of how someone is doing, that they can predict. We just published on this. They can predict future 30-day risk of suicidal ideation and potentially, although I've said that doesn't always predict suicide behaviors, but actually suicidal behaviors as well. So there are a whole range of things that can be done beyond the traditional screen. So it's incorporating into the workflows. It's looking beyond the traditional screens, looking at ecological momentary assessments, looking at the types of questions that we're asking with our screens. Sometimes when you ask someone, are you suicidal? They're not going to answer affirmatively, but if you ask them, how unbearable is life right now, they're going to address that. And that may be picking up on risk that was hidden. Natural language processing, another rule-bound logic, right? That people will often journal things that they will not journal things that indicate there's a risk, but they're not answering questions affirmatively on a PHQ-9 or an Ask or Columbia. For a whole variety of reasons. I mean, part of it is that sometimes people will write something that they won't put in a questionnaire. Part of it is how incredibly fleeting the suicidal ideation is, and the time between onset of suicidal ideation and suicidal behavior can be minutes. So it's really important that we have ways of tracking these changes that can occur in a sudden and very discontinuous way that speak to acute risk. And then I think the other thing is, when patients are at the most acute risk, they often get pulled from the continuity of care that they've grown accustomed to. They go to emergency rooms, they go to intensive outpatient programs, if they're lucky enough to be able to have access to one. And they're pulled from the caregivers who know them well. And we have to do a much better job of having a continuum, a thread that helps to tie the care together and ensure that there are ways of preventing patients from bouncing back. As we know, a significant percentage of patients, when they're discharged from an emergency room, will bounce back to that emergency room. And there are care navigation methods using humans and technology and various other things to actually mitigate and minimize that risk. So you can really have that continuity of care and minimize the recidivism and return to emergency rooms and inpatient care and so on. So those are some of the ways that we can try to manage this.
That's great. Thank you.
Brad, could I ask
sure.
Tom a question?
Yeah.
Tom, that was just like a plethora of great content. And one of the things I'm thinking about and taking notes is, and I'm a population health scientist, and so you think about what is it that we can do to impact the broad population. And I don't think we've done a good job in, and Dr. Garrett, please, you as well jump in here, is looking at how do we support providers in a way that whether they, because as you stated, most providers, unless in the behavioral health ecosystem, have had very little training. And we already are asking providers to do so much. We need an easier button for our general practitioners, our primary care providers, because we know patients are presenting, but then we put the providers in such a tough space, because if we don't have the resources or we don't help bolster their education, or because I hear it all the time, I'd love my patient to not only be on anxiety medication, but also go to therapy, because we know when we do therapy and medication together, we have better outcomes, but I don't know where to send them. What do you think we can do to bolster that provider support? Because we're already asking providers to do so much.
Yeah, it's such a great question and something I think about so much, and it really speaks to the quadruple and really the quintuple aim, right? If we don't look at provider satisfaction in addition to equity and all the other things that we focus on, we're not gonna make any headway. And providers, I think, are well intentioned and trying to do the best they can, but it is impossible to manage the psychosocial issues, and then all the medical issues on top of that for a primary care doc or oncologist or others. And they often have minimal training to do that. So just to tell you a little bit about my background, I mean, I was at the University of Washington in the late 1990s and had the good fortune of working with Wayne Caton and others who created the collaborative care model, and I'm steeped in that tradition. And I feel like I helped to carry on Wayne's legacy and feel very strongly about that. It's a wonderful model. But the reality is, in the 1990s, we were thinking, okay, this is great. We will have this model everywhere within 10, 15 years. Here we are, 90 randomized controlled trials later, and the uptake has been, and that's a whole nother discussion. I don't want to take us down a rabbit hole there, but it's a whole nother discussion about why that hasn't. And I'm still optimistic that there's going to be more and more of that. And North Carolina, I mean, 120%, that's the Medicaid, right? 120% of Medicare, that's doing a lot toward driving that in the terms of those collaborative care CPT codes. But the reality is most medical settings don't have robust integrated care models. So we have to recognize that, and we have to be able to provide the clinical decision support to physicians. And, this is where, this is the bane. It's both the wonder and the bane of EHRs, right? I mean, it's a source of such burnout for physicians, and it is an albatross, but it's also a beautiful thing. And now that we have LLM, it's a whole new world, because I'm old enough to remember the hard copy charts that read like a book and you could go back and forth. And I frankly miss that. But now with LLM, you have the capacity to pull from EHRs in the most sophisticated ways, to distill critical information, to find it really quickly and provide synopsis, that just what the primary care doc needs, just what the oncologist needs, to make sure that they've identified patients, and then clinical decision support. It's so, dare I say it, it's now become so easy to do with sophisticated LLM models that you can provide that decision support for primaries, for oncologists, so that they're not flying in the dark and wondering what do they do. I mean, and I'm not in any way suggesting that we shouldn't continue to pursue integrated care models, whether it's collaborative care, primary care, behavioral health, charity care, whatever model it is. Clearly there's huge benefit, but we know that's not going to be universal. And so we have to do more to provide that level of support. And while there's Project Echo and e-consults and all that, and that's wonderful, it's not sufficient. It's not realistically sufficient to do that. And so now that we have this burgeoning technology, I think it's a whole new world, quite frankly, and being able to provide in the moment that support in moments to specialists, to primary care docs, is mission critical, and I think will make a substantial difference. There will still be resistance. There is still, I've spent the better part of 30 years working with physicians and other specialties, and there's a lot of resistance to prescribing and this idea that we really need someone else to take over the behavioral health care. And in a perfect world, maybe that would be okay, but we know we can't do that. There are too many workforce challenges, and just not going to happen. So we have to make it possible for them. We have to understand that it's an immensely, as you were saying, an immensely difficult situation for our colleagues in other disciplines to manage these problems. So we got to do a better job in giving them the resources they need. But we now have that ability. So I hope that answered or began to answer. It's a big question.
It's a great dialogue. And let's turn it back to 988, Cara, in somewhat of a similar parallel. Obviously, the national rollout of 988, and in many ways enabled by Vibrant Emotional Health, has been a huge step forward for all of us to make it really easy, memorable, timely to get access to crisis services when somebody has one of those in the moment elevated risk events that Dr. Zalba was referring to. What is the opportunity and need both upstream and downstream of that, right? It's at a critical point. We are now in a much better spot to be able to show up in a helpful and valuable way, but we know that is a very limited intervention in a long care continuum for people who may need much more. So can you just talk about both the upstream and downstream opportunities to be able to complement what we have already made there?
Sure. And Tom, thank you. I know I pitched you a big, bulky problem, but I think it's really important we continue to talk about how do we support the providers, no matter what their specialty is, in addressing. And Dr. Garrett, you said it at the beginning, that mind and body, that head and heart, they are not separate. When I turn to 988, so Vibrant's role is in partnership with SAMHSA as an administrator of 988, and we work with states and 213 crisis centers across the US to answer the calls, texts, chats for people often in crisis, but even before crisis, which is fantastic. So 988, over the last 2 years, we've initiated 10 million interactions. 10 million interactions across the United States. And what we're seeing is, when you think about the top 5 reasons: depression, anxiety, self-harm, relationship issues, financial concerns, and self-worth. And so when you think about those reasons, we have to get upstream for so many reasons, but there is a lot of things we can do about anxiety, depression, self-harm, financial, self-worth, relationship. And so we not only need to get upstream and make sure that we have, care systems and community resources and conversations taking place that really support people throughout their life, but also after initiation or an interaction with 988 or a community crisis center. What's the follow-up that we're providing? And again, less on the, are we checking the box that we had follow-up within 7 days, 30 days, more on the, what's the follow-up and what's the depth and breadth of that follow-up? Because the person, what we're seeing when they're engaging with 988, it might be for that moment in crisis, but it's multifactorial. It might be that they have a serious mental illness and they're in they're having financial struggles and they are having relationship issues. So helping that individual address the multifactorial ecosystem is really important, because if we just help with, that depression, that's great. And we have to make sure we're wrapping around all the other support so that person isn't back in crisis without addressing the full picture. The other thing I would say is that the crisis centers that we work with and the community mental health centers, they're really doing a fantastic job in ensuring that the resources are community-based. So one of the things we just were able to roll out with 988 is geo-routing. And so geo-routing, think, I live in Minnesota. I have a Minnesota phone number, and right now I am in Hartford, Connecticut. Well, geo-routing, if I'm in need of services, is going to get me connected to services right here in Hartford, Connecticut, so I can have immediate support in a timely manner. And that geo-routing is a great advancement in technology, and also is getting us connected in that community ecosystem. So there's a lot of work to be done to get us upstream. I also look at 988 as such, it's such a great population health approach, such as 911. And we have to help people understand that they don't have to do this alone. And 988 just isn't for when you're in crisis. It is to get you help before crisis, to help you understand what's available for you or your loved ones, and to really drive the importance of mental well-being, because all of us have an experience, either our own mental health disruption or that of people we care about in community. And so we need to use our system in a way that supports people in an ongoing, seamless manner. So we're just scratching the surface with 988, and it's just one player. And it's why I ask questions about providers, because I need to make sure that we have providers that are taking care of themselves and have the resources they need so they can support the people they care for.
That's great. Thank you. Well, there have been a number of clear themes here that we've touched on. Obviously, the opportunity to use new approaches in screening, predictive analytics, care navigation, population health, and clinical decision support, the full gamut of the care continuum. Also a clear theme, I think, that there is no one stakeholder that's going to be able to do that all themselves. And in order to roll these out, we really need to think about an integrated ecosystem with clear collaboration. And so let's move in now to Q&A, because there are a couple of questions coming in that sort of touch on these themes. And we've got about 15 minutes left. The first one, and unsurprisingly, a great and timely question is, how do we see the pros and cons of using AI in this space? What are the opportunities? What are the limitations? And what are the risks of doing so? And so, Dr. Zobler, do you want to, you touched on it a little bit, do you want to elaborate and expand a little bit?
Sure. Yeah. So there are risks, and we have to be mindful of them. And there are certain precautions you can take to make sure that there is not bias, to make sure that you're addressing issues around equity, that we're not taking all the biases that exist within the cultures that we live every day and is out there on the internet, and incorporating those into LLM models. And there are ways of doing that. And it's also very important to validate the trials. I mean, there's a movement to, same way we have a registry of all clinical research, there's now a movement to maybe have a registry of trials using AI technology. So I think that there need to be some guardrails. Absolutely, there's always got to be a balance between facilitating significant advances in terms of what we can do within our healthcare ecosystem with this, and at the same time making sure we're not getting ourselves into hot water. So that just speaks to some of the guardrails. But in terms of where this is taking us, there's a lot of promise. We've already touched a little bit on how AI can be used to really distill critical information from an electronic health record, and I'm sure everyone on this call is very familiar with how difficult that can be, where the progress notes can be very fragmented. It's very hard to do a search across the entire EHR, and so using technology that allows us to distill that information is really, really important. So that's one. Two, it's using technology increasingly to identify risk. So, there's a lot of talk about categorical versus dimensional ways of going about diagnosis. And, for those of you who are familiar with what's called research domain criteria, we've struggled with having biomarkers to really have biological correlates of depression. And right now we rely on a nosology that categorizes people into different disorders. And so you can have someone with depression who is lying in bed and crying and suicidal with depression, and you can have someone who is not able to sleep at all, doesn't want to get in bed, highly agitated, can't sit still, and they're depressed. Probably not even the same illness, but we call it depression. And so now, there's a universe where we're looking at computational methods. So the whole field of computational psychiatry, right, is looking at ways to establish markers, biomarkers, if you will, that are out there and accessible through sophisticated technologies to establish what someone is experiencing and what the risk is and how can you treat it. Pharma is very interested in that. I think that medical providers need to learn more about this, but I think there's a whole new universe out there. So whether it's digital phenotyping that I'm sure all of you have heard of, where you can look at how an individual interfaces with their phone or their actigraphy data, how active they are, to use that data to discern how one is doing emotionally, psychiatrically, voice sentiment analysis, voice is a biomarker. I mean, there are a lot of things. So I think, and then again, looking at big data as a way of identifying risk and honing in on diagnostic clarity and intervention. So those are just a few ways that AI is just taking us to a whole new place that little scary. Guardrails need to be in place, no question, but holds tremendous promise.
Thank you. Moving on to another question about a lot of the challenges in the logistics and the information sharing in a care coordination environment. Dr. Garrett, for you on this one, if we imagine a patient moving from outpatient medical or mental health care to perhaps an ED visit to an inpatient stay, out to an IOP program, and back to that outpatient care, how is data being shared, and how are updates being shared out to those providers and those disparate stakeholders, as well as their payer today? And how well is that working? What are the gaps and opportunities?
So probably not as well as it should be. This is sort of one of the challenges, is that for all of the things that we have within EHRs, they're oftentimes within that EHR, and they're not necessarily shared well across systems. This is a particular issue when you're looking at EHRs that sit within behavioral health spaces, because many sort of small, medium-sized behavioral health providers have behavioral health focused EHRs, sometimes homegrown EHRs, sometimes EHRs that I've worked in that are glorified Word documents and really don't have the good ability to communicate in any way. There are some aspects of this communication across levels of care from an automated place that work okay with some of the ADT feeds that come in. That's not necessarily always the case, in particular with a lot of behavioral health settings. In some states, behavioral health hospitals and behavioral health residential settings are not within those ADT feeds. So there's not a way without folks actually receiving a direct call to find out necessarily. So there are some times where from the health plan side, it may not be finding it out until there's a claim that's made, which is less than ideal. On the provider side, they may not find out until somebody comes in and says, hey, this is what happened for me. This also comes up, in even more deep ways when we're looking at substance use treatment and 42 CFR Part 2 and some of the restrictions there in terms of being able to get and being able to share some of that information. A law which was put into place in order to protect folks' privacy, which is incredibly important, and in ways that make it more difficult for some of this data sharing piece. And so I think that across time, there are a lot of opportunities within care management spaces, within some of the data spaces, getting folks on board, technology enhancements, technical assistance for technology, because again, this is where small to medium-sized behavioral health providers may not have administrative staff. They may not have folks who are able to dive deeply into some of that tech background. They may not have some of those same data sharing capabilities. And so I know that that's one piece that as North Carolina Medicaid is looking at some of the monies that they got as a part of Medicaid expansion this past year. Part of that is to go towards technology aspects for behavioral health. We're not there yet by any stretch of the imagination, but I think that things are moving in the right direction with that in terms of improving that communication, improving that transition between levels of care, improving the ability to refer to and from levels of care, because, I remember the day of calling 25 hospitals and every hospital in the state to say, hey, do you have a bed open? It's 3 a.m. and I'm calling, and no, you don't. Okay. Or, oh, you don't really want this patient because you have had this patient and have had issues with them. So if we are able to get to that point, I think that a lot of those efficiencies that'll be streamlined, that in and of itself, I think will increase some of the bandwidth in terms of workforce, because some of what we need to do, whether it's through using some of the language learning models like Dr. Zobler is talking about, or through, utilizing the resources we have, including 988, including others, by building some of these efficiencies, we can increase the amount of time that folks who are working in the behavioral health space are able to spend caring for patients rather than doing all of these other pieces that are clunky.
Thank you. Cara, last question over to you. We had a question that if you could wave your hands and fix one problem in this broader ecosystem and all these interwoven challenges we're talking about, what's the thing that you would focus on?
Oh, gosh, that's a no-brainer for me. We put the heavy lift on the person who needs the help, care, and support. Figuring out, gosh, what's happening with me? We expect people to maybe have an idea. Who do I see? If I have insurance, is this covered? Is that covered? Do I see a psychologist, a psychiatrist, a social worker, marriage and family therapist? I would like technology that helps pull out that confusion and meets people where they're at without adding one more barrier and leaving them when usually people are burned out at their lowest with all the work. And we have other areas in the world that have done this. You know, we have, if you think about other innovations that have happened. So how do we keep the patient, the person at the center and not make them do all the heavy lifting, and democratizing access to really good care? Because I also want to make sure that people aren't taken advantage of when they're in their most vulnerable state. When I was at CVS Health Aetna, the worst part of my job was talking with parents who had, sent their child to their third facility across the country and were told they're going to get X, Y, and Z, and their child is going to be better, and they weren't. And, it's devastating. Those parents had mortgaged their home for the third time and now we're bankrupt. So how we can take technology and make it easier, more streamlined, so that the patient, the person doesn't have to do all the lifting. That's a big ask. That's a big magic wand, but I know we can do it. We've done it with, we have cars that can drive themselves. We can figure this out. We just need to put the right infrastructure and creative minds on this task.
Thank you so much. And thank you to all of you on the panel today and everyone who attended. What a great conversation. Really insightful perspectives, tangible, actionable focus areas. Really excited for the momentum that's building in this space, for the increased focus on not only the tools, but the nuances and specific subspecialized needs of the populations that we're looking at and the opportunity ahead. So look forward to the ongoing dialogue. I know we will be at Health. I imagine many of you will be as well. So please come find us at Health and let's continue the dialogue and keep pushing forward together. Thank you, everyone.
Thank you to Brightside Health and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health GoLive webinars. And join us in Las Vegas, October 20th through 23rd for Health 2024.